I'm going to talk about these tools that we have in practice about how to estimate cardiovascular risk if we are overestimating or underestimating the risk. And actually, I would like to add another question here. What are the clinical consequences of that? And I will try to answer these two questions in my presentation. Well, you all know that risk scores, cardiovascular risk scores, are widely used for making decisions in primary prevention of cardiovascular diseases, and often through recommendations of clinical guidelines. And using cardiovascular risk scores as decision tools may imply changes in patients' healthcare management, specifically in treatment with lipid-lowering drugs and sometimes with antihypertensives as well. Perhaps this is the most popular and worldwide well-known guidelines that we have that have been published. We have the European Guidelines on Cardiovascular Disease Prevention in Clinical Practice. We have the National Institute for Health and Clinical Excellence, what is called a NICE, from UK, still in Europe, not for too longer, unfortunately, in my opinion. And then we have the ACC, AHA, which is the American Heart Association guideline on the assessment of cardiovascular risk. The European Guidelines on Cardiovascular Disease Prevention was published, the last version was published in the year 2016, and I was very honored to be one of the authors representing the European Society of General Practice, WONCA Europe. In fact, there were 10 European societies represented in the guideline that we work all together. And they do recommend the score, which is a system based on European cohorts. And this is the popular color table. In this case, this is for low-risk countries. It's a very simple tool that takes into account the age, gender, blood cholesterol, blood pressure, and smoking. The European guidelines do recommend three categories of groups: the very high risk, with the recommendation of an LDL cholesterol less than 70 milligrams per deciliter, which is 1.8. High risk, with a LDL goal of less than 100 milligrams per deciliter or 2.6 millimoles per liter. And the moderate cardiovascular risk with the goal of LDL less than 150. Then we have the NICE. The NICE recommends the Core Risk 2. Actually, they already have published the Core Risk 3 that have included more factors, more parameters in the equation. And to assess cardiovascular risk for primary prevention of cardiovascular disease in people up to and including age of 84 years. They offer, and they are very clear on that, they offer atorvastatin 20 milligrams for primary prevention of cardiovascular disease to people who have 10% or greater 10-year risk of developing cardiovascular risk. And also NICE recommendations do not stipulate therapeutical targets for LDL as opposed to the European guidelines that I have just shown you. So therefore, all patients at high risk are considered candidates for lipid-lowering drugs, and specifically they do recommend this drug. And this is the website of the, in this case, the Core Risk 2, but as I said, they have already published the Core Risk 3. And this is the American Heart Association guideline on the assessment of cardiovascular risk that was published in the year 2013. And this is the equation among asymptomatic population. And the risk estimator is intended, is the tool recommended in the guidelines to assessment the risk, to treat blood cholesterol, And also, as I said, for the NICE guidelines, the American guidelines recommendations do not stipulate therapeutic targets for LDL. Therefore, again, all patients at high risk are considered candidates for lipid-lowering therapy. And this is the website that also you can compute the risk. And also, the Americans have published this algorithm where, regardless of the risk, if the LDL is higher than 190, these patients are considered high risk. So also they are candidates for lipid-lowering drugs. So we have the three tools here, very popular tools in practice, and they have, as you can see, differences. I'm not going to go into detail because there are many details in the different tables. But as you can see, at the bottom, the threshold for the score is 5% or greater in the next 10 years. This is the threshold of the risk threshold. For the American guidelines, the threshold is equal or greater than 7.5% in the next 10 years. And for the Q-risk, the threshold is equal or greater than 10% risk in the next 10 years. But as you can see, the endpoint is different for each tool. So the endpoint for the score is fatal endpoints, while the endpoints for the American and the endpoints for the NICE are cardiovascular disease morbidity and mortality. That is the reason why the thresholds are different. So to answer these questions, we did evaluate and compare the impact of the American, British, and European guidelines on the identification of high-risk patients and on the percentage of patients requiring lipid-lowering drugs or statin therapy. And for that, we use a Spanish working population in primary care. We use a big cohort that we have of Spanish workers who underwent a medical examination more than 10 years ago, between 2004 and 2007. Actually, we did follow up this population up to now. And the score, we used the score for lowest risk countries, the American and the British guidelines, and diabetic patients were excluded. And as I said before, the European guidelines have 3 different categories with 3 different targets for lipid-lowering drugs. Also, as I said, NICE and American guidelines do not stipulate therapeutic targets. And on top of that, the American recommendations treatment on lipid-lowering therapy, they do consider that when LDL is higher than 190 milligrams per deciliter, regardless the cardiovascular risk. So we have a sample size of more than 200,000 workers all over Spain. About 75% were men, and about 43% were smokers, and the mean age was about 48 years. About 10% were hypertensive. Of those, 71% were treated. About 11% had the diagnosis of dyslipidemia, and 33% of those were treated. And this is the algorithm if we have to apply to this population the European guidelines. So as you can see, we have the full population, 227,371 individuals. And from those, we have a score between 5 and 10, which is a high-risk score of 3.95%, and a score higher than 10%, which is a very high risk, of only of 0.47%. So this is the percentages of high-risk patients according to the score, according to European guidelines. And if we look at the NICE, and according to its recommendation, here those individuals equal or higher than 10% were about 18% of the population. And if we apply the American guidelines, which the threshold is equal or higher than 7.5, it's about 26% of the population are considered high risk. But also those patients that have LDL higher than 190, which is about 10%, also should be considered high-risk patients. So as a summary, from this population, and comparing the different guidelines, with the European guidelines, we have 4.4% considered high-risk patients, but with the NICE guidelines, 17.8% are considered high-risk patients, and with the American guidelines, 26% are considered high-risk patients. And according to that, 3.9% should be treated because there are some patients that were already treated. According to European guidelines, 16.4% should be treated according to British guidelines, and almost 32% of this population should be treated according to the American guidelines. And if we look at the results in a different way, at the time that we did the examination, only 0.31% were treated using the European guidelines, 1.36 using the British guidelines, and 1.75 using the American guidelines. But according to the guidelines that we have at the present time, 4.2% percentage of the population should be treated, which is about 9,550 patients out of 227,373 patients. According to the guidelines, the NICE guidelines, almost 40,000 people should be treated out of the total population. And according to the American guidelines, more than 76,000 people should be treated over the total population, out of the total population, according to the American guidelines. So as you can see, there are big differences, not only in the estimation of the percentage of high-risk people, but also on the total population that should be treated, in this case with lipid-lowering drugs. So in conclusion, the application of the British and American compared to the European guidelines would result in identifying more high-risk patients between 4- and 6-fold increase, and in treating larger fraction of the population with lipid-lowering drugs between 4- and 8-fold increase, and eventually with other intensive preventive pharmacotherapy such as aspirin or antihypertensive drugs. So it's important that we need to interpret cardiovascular risk estimated with caution in order to avoid overestimation of risk and overtreatment. This is my team. It's my second family, actually, in Barcelona. And thank you very much, and muito obrigado.